record.
This meeting is being recorded.
Yep.
Okay, well,
That's
that'd be
what it
good then.
says.
All right,
meeting
so
is
let's
being
get
recorded.
started. All right, so let's get started then. All right, everybody. Welcome to another edition of the Leadership Blend Live podcast with your host, Ricardo D. Rice. And this is a very special episode. It was brought to my attention by somebody very dear to my life that this month is National Brain Tumor Month. So what better, y'all know how I do. So I went and found some great people, one who's lived through it and one who actually is in this field to really explain what all this means. What does it look like, particularly for people of color? You know, what are we not seeing? Just everything, the holistic picture. So I'm excited to have these two doctors, and I love you, but these two doctors, and I use for amazing people on the show today. So I'm going to start with, y'all excuse me, she's like my other mom. She's my best friend's mother. She wants me to call her Dr. EC. So that's what we will call her, but she's gonna have to give y'all her real name. So I'm gonna let her introduce herself first.
Well, hello, leadership blenders. I think that's what you call them. I'm Jo Evans Coleman, Dr. Jo Evans Coleman, EDD, PhD. And yes, Mr. Rice is my surrogate son. He's my daughter Danielle's best friend. And I have joining me today one of my dear, well-respected neuro-oncologists, Dr. Ekokobe Fonkem of Baylor South, how did I get it wrong? Baylor Scott White Health System. He's also a member of Meningioma Brain Tumor Network, Inc., which is my nonprofit that looks at meningioma brain tumor survivors, because I happen to be one.
Yeah, I'm excited to hear, your whole journey with that because, yeah, you're a walking testimony. I can definitely say that. All right, I'm not even gonna try to butcher his name, so I'm gonna say Dr. Dr. E. What you call him, Mom? Do you call him Dr. EK?
I call him EK.
Okay, so we're gonna say Dr. EK because I refuse to butcher his name. So Dr. EK, tell everybody about you.
Thank you for the wonderful introduction, Mr. Wright and Dr. Coleman. Thank you for inviting me on the show tonight. As you all said it right, my first name is Ekokobe, last name Fonkem. I'm a neuro-oncologist by training, and I also happen to be the system director of neuro-oncology at Baylor Scott White Healthcare System in Texas, which is probably one of the largest integrated healthcare systems here in Texas, and also a professor of neurology and neurosurgery at Texas A&M and Baylor College of Medicine.
Wow. Okay, so let's just get right into it. Let's jump right into it. So let's start with what exactly, and this is for Dr. EK, we'll start with you. What exactly is a brain tumor? Like, we hear these things, but most people don't actually know what that is. Like, logistically, what is a brain tumor?
Oh, thank you for that question. I think that question can mean multiple things to multiple people. But a brain tumor, as some people call it, can either be cancerous or benign. But a definition of a brain tumor is any mass that is found within the brain, and it can be, as I said, benign or cancerous. In terms of brain cancers in general, brain cancers account for about 1.2% of all cancer diagnoses in the United States, but collectively cause about 2.4% of all cancer deaths, of which glioblastoma, which recently took the lives of one of the most famous uncle in Atlanta, Georgia, probably about 6 months ago, where the lady was diagnosed with a glioblastoma and she was dead within a year. So glioblastoma is probably the most common form of a brain tumor and also the most aggressive. And we'll know about this a little bit more now than we did before because of Beau Biden, who was the son of President Joe Biden, who died from a glioblastoma as well, or John McCain, who also happened to have pass away from a glioblastoma. But of course, we also have some other tumors like what Dr. Coleman alluded to, like meningiomas, which seems to be very common. And the majority of those tumors actually might have a benign characteristics in that they do not have the same kind of mortality that we see with glioblastoma, but yet can cause a lot of problems in terms of mobilities. And we tend to see most of those meningiomas in our own Black community. In my own practice, about 30 to 40% of the meningiomas that I see are either coming from folks who look like me. And this is the kind of tumors that for a long time we thought they were quote unquote benign. But some of these can be very aggressive to the point where they might require surgery, radiation, and in some instances, even chemotherapy. And yet, we just haven't been able to do a very good work in terms of advocacy research. And that is why Dr. Coleman created a National Meningioma Brain Tumor Network as a way to bring awareness to meningiomas and also to the effects that these tumors have in our own communities.
Okay, now this might be a silly question, but I'm going to ask because I'm very curious. So we talk about brain tumors, and when we speak about that, in my head, I think about things like an aneurysm. Are those even on the same wavelength? Like, I'm just curious, for my curiosity.
Aneurysms are disorders of blood vessels, or what I call abnormal blood vessels in the brain. Tumors are brain masses that can grow and cause a lot of problems in the brain because they can cause headaches, they can cause seizures, they can cause problems with our movement, they can cause problems with the way we think. And if some of these tumors were to be left unchecked or not treated, they can actually result to death.
Okay. All right, so let's segue. I got two doctors. I got one EC and one E. Okay, so forget all that. Dr. Mama Joe. So that's what I'm calling you today, Dr. Mama Joe. All right, so so let's get into your experience with this. Like when this happened to you, did you have symptoms that you didn't know? Did you kind of shoo them off? Because African Americans, we have a tendency to do that. Oh, we know it's nothing, or it'll pass in a couple of weeks. How did it start with you?
Actually, I had an international assignment where I had actually been away from the stateside for almost 18 months. And when I returned in January of 2014, I started to have symptoms of dry eye. And it was both eyes, it wasn't one eye. And I alluded it to my needing additional lenses. I wore bifocals for reading and distance, probably for 10 or 15 years. So I thought, okay, I'll just go to my optometrist, get an eye exam, change my lenses prescription, and on my way. I went to my optometrist and he did his examination and he said to me, the lens in that right eye is kind of off. And he said, and so your vision has changed considerably since 3 years ago, because I would go every 3 years to get my eyes checked. He said, and I'm not liking that because it's causing ptosis. It's causing proptosis. So what was happening is my right eye, the eyelid was open further than the one on the left side. And so he wrote all that down on his prescription. And then he said, you know what? I think you need to go to the Wilmer Eye Institute and get a full workup. Well, in between my eye appointment in January, since I was back stateside, I went to my family practice, who happened to be female, and I told her about what he had said. And she said, that might be a good idea to do that. Well, before I made the appointment at Johns Hopkins Wilmer Eye Institute, I thought, you know what? I'm menopausal. Let me go to my endocrinologist. So to answer your question more directly, no, I'm not one of our people from the community that don't monitor my health. I've always been that way from the time I was in my early 20s, and I am now 66 years old. So I went to an endocrinologist. She did all the tests because I thought maybe it was a thyroid issue. At the time, I was 58 years old. That's the time when women that are menopausal have the beginnings of thyroid disease. She did all the tests and she said, well, I won't have the answer until 2 days from now. She said, so you told me you're going to be going over to the Wilmer for your eye, correct? And I said, yeah. She said, well, let me know what that's like. Well, I was at the Wilmer 2 days after my endocrinologist appointment. I go to the ophthalmologist, general ophthalmologist at the Wilmer for an early morning appointment. And there was a fellow that was working with the assigned ophthalmologist. The fellow was a female. And she did the regular eye exam and she said, I'm reading the notes from your optometrist and I want to look a little bit further. She said, so let me send you to the outpatient clinic to do a CT. And so she put it in the system. Anyone that's ever been to Maryland and know Johns Hopkins, the hospital covers about 10 city blocks. So I had to go all the way to the outpatient clinic inside the hospital. Got the CT done. By the time I got back to ophthalmology, she looks at the images and she said, you know what? I'm going to order an MRI. So I go back to the imaging center in the outpatient clinic to get the MRI. And she did it with and without contrast, which is with the dye, takes longer. So get that done. I go back and she brings up the images and I'm sitting there like most people. I pull out my phone and I'm working. And she kind of glanced over her shoulder and she said, I know what you have. And I looked up from the phone and I said, yes, and what's that? She said, you have a meningioma. Well, I knew gioma meant tumor, but I wasn't quite sure what the meninge was. It didn't dawn on me. She was talking about the meninges of the brain because I'm there for an eye exam. And I said to her, I said, in my eye? And she goes, no, flips her hair and says, in your brain. And she walks out because now she has to go get the attending ophthalmologist to come in. And I'm sitting there, I'm befuddled. And when she walks back in with him and he looks at me and he says, have you been in an accident recently? And I said, no, why? He says, well, most of the time we see meningiomas, they're coming from some type of trauma. And that oftentimes will lie with accidents or, sports injuries. And I said, no, neither of those. He says, well, he shows me the area in my brain, and it actually covered all the way from just above my ear on the right side over to my eye socket and into the center of my brain. That's how much it covered. Now, meningiomas are not necessarily masses. On the meninges, it's more like the meninges is like the covering of the brain. So I always say like the cellophane wrap. It's clear like that, but the growth of it is cell-based and it looks like mold. That's what it looked like to me. It looked like mold from the top of my ear all the way to the center of my brain. Then they referred me up to neurosurgery. By this time, it's 11 o'clock in the morning. I was there all the way until 6:30 that evening, because now they have to assign a neurosurgeon to the case so that we can go forward. So that's how I received my diagnosis on July 7th, 2014.
Okay, that's we'll get back to that story because we'll get back to that story.
Sure.
Okay, Dr. Ike. So with these kinds of tumors, what do the options look like? Is it surgery? Is it chemotherapy? Does it vary depending on the size of the mass? What are we looking at? Like, how does that work?
Thank you for that great question, Mr. Wright. I think if you look across, meningiomas are by far the most common tumors you'll find in the brain. And usually, if you just randomly were to get a CAT scan of 10 people walking around your environment or my environment, you'll probably pick about one that are common. But the good news is that most of these meningiomas by far tend to have a very benign course. However, you have a small fraction that for some reason start to develop, start to grow a little bit aggressively to the point where a patient might start to develop symptoms. And those symptoms might be what Dr. Coleman alluded to, like maybe difficulties with vision, headaches, seizure, maybe change in mentation. That might cause them to seek help by going to see a doctor. And at that point, they can get a CAT scan, which can also be preceded by an MRI for more better visualization. Then once an MRI comes back and they say this looks like a meningioma, oftentimes you really need to be able to have a tissue diagnosis. And that is the time when you go to a neurosurgeon to say, hey, doc, I know I had this scan done and it showed this mass. But even though it looks and it felt like a meningioma, you cannot say with 100% accuracy that it's a meningioma. Because what if the mass was something like a brain metastasis, or if it was a different kind of tumor? So you really need to be able to get a biopsy at least to be able to confirm that diagnosis. And in some cases, because the surgeon is already going to open your brain, if the meningioma is located in a good location, the surgeon might just choose to completely remove that tumor. And usually, the way we classify meningiomas is based on grade 1, grade 2, grade 3. So if you have a meningioma and you have a resection and it's a grade 1, oftentimes that is all what you need, because the rate of the chances that the tumor will come back in 5 years is less than 5%. However, if you have a meningioma and you have that resection and it comes back, the pathology comes back as a grade 2, then in that case, you also need, in addition to surgery, you also need treatment with radiation, because the chances that that tumor will come back in 5 years now increases to 25%. And the third scenario is if you have that meningioma and you decide to go through surgery and have surgery, and it comes back as a pathology grade 3, which is the most aggressive. In that case, you probably will need surgery, radiation, and even in some cases, chemotherapy, because the chances that that tumor will come back in 5 years now goes up to 80%.
Okay, so let me ask this. So is radiation and chemotherapy different? Because I thought radiation was a part of chemotherapy. Are they two different things?
Yes. Radiation is using almost like a heat, and it's very localized to burn or zap a tumor. Meanwhile, chemotherapy means chemicals. You're using chemicals that you give to the patient in order to see whether you can control that tumor.
Oh.
And oftentimes, chemotherapy is either given by mouth or is given through an IV. Radiation is given with the help of a machine.
Okay, that's okay. I learned something new today because I thought radiation and chemotherapy was kind of in the same space. So I learned something new today. Okay, so let me ask you this while we're in this space. Where does this come from? Is it a hereditary type thing? Is it conditions that you may live in? Like what kind of festers these kinds of things?
Great question. I think with meningiomas, like any other tumors, we do have an hereditary or what I call a genetic component, and we also have an environmental component. And we see that not only in meningiomas or other brain tumors, but this is true for all kinds of tumors. And in our own community, I think the environment is playing a big role. For example, we published a paper 2 years ago where we showed on that paper that where you live in Texas, I mean, the county you live in Texas, we could use that county to predict the risk of developing a brain tumor. So there are some regions, because the kind of industries found in that, or the kind of pollution in that space, that probably puts some people at risk of developing a brain tumor, including a meningioma. And also because of our own lifestyle, I know some of the meningiomas from what Dr. Coleman alluded to, some are due to head trauma as a risk factors. Some are also due to hair dye. I know we come from a community where we really like to put or use a lot of different hair dyes. And those have also been implicated as risk factors for meningiomas. I know there's been some talk about cell phones causing brain tumors, but that data is still very early, and at this point, it's very difficult to draw any conclusion. Then the other risk factor is just the ionizing radiation. We know that folks who were exposed to some form of radiation, either as kids or even as adults, are also more prone to developing brain tumors, including meningiomas. And the third risk factor might also be genetics. If you're exposed to certain hormones in the body, such as progesterone, estrogen, testosterone, that might also be a risk factor for some of these brain tumors, including meningiomas, yes.
Is there a statistical difference between men and women as it pertains to brain tumors?
Yes. In terms of glioblastoma, the incidence is a little bit higher in men compared to women. However, if you look at meningiomas, we tend to see more women more than men, and more meningiomas in more women of color, especially Black women, more than their counterpart.
When you said hair dye, I immediately thought of my three sisters and my mom. I was like, Lord, they love to dye their hair and wear weaves and all kinds of stuff. So I was like, that immediately right there made me concerned. Okay. All right. So let's go back to Dr. Mama Joe. All right. So let's pick up where you left off and get a little farther in your story.
Well, after the diagnosis with the imaging, and I met with the neurosurgeon that was assigned. I'm one of these people that I like to choose my healthcare providers. But in the neurosurgery department at Hopkins, they were assigned by the chief of neurosurgery. Now, that particular chief was the best, had the most experience with doing craniotomies for meningiomas, but he no longer entered the surgical suite, which was very disappointing to me. So then I decided to have additional consultations. I went to the University of Maryland and met with their chief of neurosurgery. And then I also went to George Washington University in Washington, DC, and met with their chief. The running theme was they all had the same story. This meningioma has penetrated your cavernous sinus, which is in the center of my brain. And they said it's not going to just stop there because of where the location is. It's probably going to enter the other side. What they could tell from the imaging, which imaging tells you a lot, but not everything, that my optic nerve had already on the right side. My type of meningioma is called a sphenoorbital, which means the eye cavity and the right side of the temporal area. That they thought it would also start to affect the ear canal area because of the location and because of how wide the location had spread. So my concern was if it moves to the left side, when we already know that there's damage on the right side, then we have a real bigger problem than what we were facing. So then I opted to do the resection, is what they call it. And I met with the neurosurgeon, and he started talking about how the location of where the optic nerve was so tedious that he wanted to bring in the neuro-ophthalmologist. And this neuro-ophthalmologist is known worldwide. I didn't know him, but you mentioned his name within the circles and everybody's just like, you got him? And then after he told me that, I said, well, describe to me what the surgery will entail. And he said, well, we're going to do a procedure that's called a C-flap, where we make the incision like a C from this part of your head to the top of the ear, and we take that part off and we remove that part of your skull because that's where the meningioma is. You know, remember it covers the brain. Well, the skull covers the meninges. And he said, and then we'll go from there. And I said, okay, so what are you going to replace the skull with? And what threw me for a loop was his cavalier reply was, oh, eventually we will go back and reconstruct it. I said, you're telling me that you'll remove it in surgery, and how long is the eventual reconstruction? He says, well, sometimes a year to 18 months.
Oh.
And I said, so what's going to be in its place? And he says, oh, well, we have a way of nothing specific. And being a neuropsychologist, I got to have specificity. So right in my mind, I said, he's talking reconstruction. Then we're going to do this as a one-shot deal because there are no redo, no do-overs. So when I left his office, I got in my car and I called one of my closest friends who is a microbiologist out of Duke. And I said to her, I want you to find me every piece of research on this disease. Everything. I want it sent to me by the time I drive home. Well, my drive home was going to be a little over an hour. And she's one of the best researchers I know. And after I hung up from her, I then went through the directory at Hopkins, since I had made the decision that I would do it there. And the reason I made this decision to do my surgery at Hopkins is at the other two medical centers, no one talked about a team approach. They all only talked about the neurosurgery. They didn't talk about the ophthalmology part, which is a big part of what's involved in the meningioma I have. And no one talked about reconstruction. They just talked about the neurosurgery. Well, once the neurosurgeon mentioned to me that he would bring in the neuro-ophthalmologist, that's two team members there. And then I knew that I wasn't going in that suite without plastic and reconstruction because I wanted it all done at one time. So I looked up in their directory, and at Hopkins, they had 4 plastic and reconstructions. And the one that was the assistant chief had the most experience with brain reconstruction, skull reconstruction. He also used a lot of technology to develop the devices, which I knew I was going to have a prosthesis in my eye socket, because part of that was the upper eye socket was going to be removed. So I knew something had to be replaced there. And what do you replace bone with? It's usually something equally durable, and it's going to be some kind of metal. Well, I took a roll of the dice and I called this plastic and reconstruction. And Hopkins has a very, I won't say unusual, but it's a very different way of having practitioners work together. In other words, being that the neurosurgeon would be considered the lead of the medical team, it's like anybody else that was going to be in that suite had to have his blessings. And so the plastic and reconstruction person asked me that, well, who is your neurosurgeon on the case? And I mentioned who it was. And he says, oh, okay, I know him. I'll have a meeting with him. And I said, well, I don't want you having a meeting with him without my being present. And I think he was shocked about that. And I'm like, but it's me that you're doing the surgery on. Why am I being excluded from the discussions?
All right, hold on. All right, so pause there, because I gotta ask some other questions, because you know you're a special case. Like anybody that knows Dr. Mama Joe, she I don't want to call you a control freak because that's not a good word, but you just that kind of person, which is why I adore you. Like you will ask questions, and let's not forget you have like 2 doctorates, so you're not exactly the average person who really goes through this. So I have to ask some sideways questions because you too much in charge of this. It's who you are. I love it, but you too much in charge of this. Dr. EK, what does this process look like to somebody who is not as in it as Mama Joe over here? Like, what is this? They get their prognosis, and then what usually happens to the average Joe?
You're right on that, Mr. Wright. I think Dr. EC was an exceptional case because what we learn in medicine is that your level of education, your resources can affect what kind of treatment you get.
Mm-hmm.
And unfortunately, the bulk of the folks who are coming from communities that look like all of us here, one, are not very well informed. 2, do not have the kind of resources that Dr. EC had to do the research, go to the right places, and be able to use their own influence to ask the right questions, right? So that they could get the right answers. And oftentimes, that could be one of the reasons why we see some of the kind of this healthcare disparities that we see today.
Mm-hmm.
But let's just walk back again and say, for example, I just recently moved back from the Neuro-Neurologic Institute where I was the chief of Neuro-Oncology in Phoenix, Arizona, until 2 months ago when I decided to go back to Texas where I had started my career. And I always said the Neuro-Neurologic Institute in a way was almost like Hopkins,
Mm-hmm.
where the kind of clientele that goes to that kind of institution are those who have the resources, they also have the connections. They're not the kind of typical patients that come in through the community hospitals, right?
Mm-hmm.
Where you might not have the necessary resources and where they go there because that is one of the few places that they might have access to care, right?
Mm-hmm.
So that can actually really make and break you because oftentimes people just are told what their care plan will look like. And they just have to, if they choose to go with that plan, then they just do that without even asking any questions.
Mm-hmm.
And again, that is in its own is another form of healthcare disparities. Because oftentimes you might have those who are not well trained on, are not well versed in that, making those decisions, or hospitals that do not have the same kind of expertise,
Mm-hmm.
making those decisions, and you as a patient thinking that you're getting the best of the best.
Yeah.
When somebody who is doing that kind of surgery, you might be one of the first subject they're actually taking for that procedure.
Absolutely.
Not like somebody who a center has been trained to do hundreds to thousands a year.
So let me ask this while we're in this space. If you get this prognosis, what are some of the questions you should ask as an average Joe? Just basic questions that you should ask out the gate for somebody that gets this kind of prognosis. What are some of the things they should ask in that moment?
Well, I always tell my patients to say, well, just because a hospital or a professional is giving you an opinion
Mm-hmm.
Don't just take that as gospel truth. That is just your own opinion. I want you to do your own research, talk to, get a second or third opinion from some other independent people. Or if you have a large group practice where you reside, don't just go to one doctor and hear. It's good to go to one doctor to hear what they have to say, but it is also good if there are multiple specialists within the same practice who do the same thing, to maybe, if you do not have the resources to go outside of that practice, to try to talk to another person within that practice just to get another opinion, so that at least you can be better informed before moving forward, because each time you fail to do your own research and something bad were to happen, it is always difficult to go back again and reverse what has happened.
Right.
This is true. Okay. All right, Dr. Mama Joe, back to you.
Well, after I met with the plastic and reconstruction, then we decided to do it as a three-way team, which is what I insisted on, because if they're all three are going to be in that surgical suite, I want to know what transpires, batter up one, batter up two, batter up three. In that meeting, the neurosurgeon did very little talking, which I thought was odd, being that he was the chief of the team. That's part of his personality. I had to learn that. That was part of his personality. Kind of aloof. The neuro-ophthalmologist, who was senior in age and in experience with meningiomas, even though he was specifically for the eye part of it, he did most of the layout of the approach. And then the plastic and reconstruction, which I didn't ask for because I didn't know it was necessary, he brought in the biomedical engineer that was going to build the devices that were going to be placed in my body. And this biomedical engineer came in using his technology, and he demonstrated, he had a prototype of how he goes about building it, how it would fit. And he actually had my images where he showed that. And then when I requested a copy of it, he said, absolutely, you can have that. So I have the CD with the prototype. Stop laughing, my son. There's nothing in my medical records
only you would do
none of
something
my
like that.
physicians have that I don't have.
Nobody else would think to do that but you. Like, it's so funny to me. It's funny, but it's not funny, because I've spent time around you, so I know how you are. It's like, yeah, let me get a copy of that. Yeah, let me get a copy.
No, I would. Well, by HIPAA law, there's nothing they should have in their possession that you, as the patient, cannot have.
I agree.
It wasn't a matter that he said, well, no, I can't give you that, because then we would have had another issue. But he said, absolutely. And I walked away with it. And then after that, we came up with a surgical date. And that was actually 6 weeks after the diagnosis. I was on the table on August 24th for 9 hours, where they took away a quarter of my skull, and plastic and reconstruction then put everything back together. Now, it wasn't that smooth because there were some challenges, and the challenges were that one, I lost the vision in my right eye because, according to the surgical notes, there was a spasm of the blood vessel right adjacent to the optic nerve. And because the meningioma was covering that, it damaged the nerve. And then the 5 muscles that hold the eye in place were also destroyed. So my right eye does not move in every direction. And then the third thing that went wrong is there was nerve damage from the cranial nerve 3 and the cranial nerve 6. 6 became palsy, but 3 became totally damaged. And I lost the up and down movement of my eyelid. So I ended up having to undergo additional surgeries for 2.5 years to make all those corrections.
Okay. So let's go to Dr. EK. Is that something that people should anticipate even after having that kind of surgery? So let's say they go in, they get it. Should you anticipate reconstructive surgery, additional surgeries after that for whatever reasons? That's something you should put in your mind if this becomes your track with something like this.
I think to answer that question, Mr. Wright, when we look at brain tumor and surgery, what happens is that the location is very important. In the case of Dr. EC, where the meningioma was located was very close to her eyes. That is why she had some of the deficit or neurological deficit that she had post-surgery. And that is why she needed to go back for more surgeries to fix the areas that were damaged, because where her meningioma was located around the part of the brain that I call them the eloquence part of the brain, almost like what I describe as a very busy highway. There's no way you can safely pass through that pathway without causing some problems. And unfortunately for her, those were some of the side effects that she suffered post-surgery. But that is not always the case for all meningiomas, because most meningiomas can reside in different parts of the brain. If you are one of those lucky people where you happen to have a meningioma that is located in a non-eloquent part of the brain, after surgery, you might not suffer any kind of deficit. You leave surgery and you're just perfectly fine. But if you are one of those unlucky people like Dr. EC, then you might have to anticipate those kind of problems that she did suffer post-surgery, and also have a plan in place as to find a way to fix those problems so that you can improve your quality of life. Because it is not only important to do surgery to remove a tumor in order to give you that longevity, what I call quantity of life. It is also important that after surgery, then that surgery, there's that kind of a balancing act, where as you try to fix quantity, you also make sure that quality of life is not compromised.
Okay, so is this one of those situations where, you know, we talk about like breast cancer and they encourage women to go get mammograms and things of that nature. Is this kind of that same space where there's something that can help early detect it to kind of make a difference, or it just kind of happens and you just kind of catch it?
Well, research has shown that for diseases where you can do something early to prevent it, early detection is very important. Like in the case of breast cancers, where if most women have their annual mammograms after they reach a certain age, or if they have those kind of genetics that makes them predisposed to developing that kind of cancer, such as breast or colon cancer, then you want to go in early, because if you can go in early, then you might be able to do something to prevent that or to decrease the symptoms. In the case of brain cancer, where we are right now, we really do not advocate for early detection by asking people to get CAT scans every year, because it's not like there's a treatment that can prevent you from developing a tumor as of yet. But we hope that one day we'll be able to get to that point. And that is the kind of work I'm currently doing in my own research laboratory, trying to find biomarkers that can be used to detect brain cancer, either in saliva or in blood or even in urine. And that is where I hope that research can help to get us to that place where we might pick them early and deal with them early before they ever pose any problems. Yes.
Okay, that's okay. One more question. This kind of goes between the two of you. We know that there are a lot of conversations about healthcare and what it does and doesn't cover. Like, Mama Jo, what did that look like for you? Like, did your healthcare that you had, did it cover everything? Did you have to come out of pockets? What does this normally look like for somebody that goes through something like this? Like, what does that look like healthcare wise, coverage wise?
Coverage wise, mine was 100% covered. Where some of the challenges started post-operatively is when I was having continuous surgery to finish or correct some of the things that surgery had caused problems with. A case in point is when I got ready to get rid of the ptosis, because I went from proptosis with the eye being open to ptosis with now the entire eyelid is closed. When I went to the ophthalmologist, who is an oculoplasty that only does eyelid reconstruction, the first thing he said was, when I do this surgery, it's usually to improve vision. Well, I had no vision in the right eye. So how do you convince an insurance company? Because now they're talking, that's not corrective. That's cosmetic, okay? That became the conversation that I was having with the doctor. And I said to him, it's all how you write the order. The order is still part of reconstructing my head. And that's how we got it covered, because automatically oculoplasty is a cosmetic procedure. It is not a corrective one. But I still see Dr. Grumbine to this day, just a wonderful, wonderful practitioner. On top of that, because the eye is blind now and some of the structures of the eye is missing, I was prone to several things, and that is my cornea in the eye started to deteriorate. Once they open the eyelid, there's no surface on the right eye. So that makes everything in there, because there's no protection, starts to deteriorate. So then another ophthalmologist had to build me what's called a sclera lens. It's a special contact lens that actually covers the entire eye, not just the iris part that most contacts covered. Mine covers the entire eye to protect what was I saying? To protect the surface of the eye, because there was none left after the surgery. And then after that, I ended up having other problems that required surgery. I ended up having what's called, it's a nasal passage condition, granulomas, that there were growths in my nasal passage that would cause me to have profuse nosebleeds. So that had to be fixed. The other thing I ended up having to have fixed was when they did the surgery under the sphenoid wing, which is a muscle. When the plastic and reconstruction released that muscle so that they could open up the skull, I learned this later, but rather than releasing the muscle from the top, he released the muscle from underneath. And when he released the muscle, it started to atrophy. And then that side of my head started to cave in. So now we got to figure out how to fix that. And that, again, that was another plastic and reconstruction surgery by another practitioner that corrected that. So all of these things ended up being things that were never predicted. That's never talked about. It just talked about the surgery of being able to get rid of the meningioma, which they could not get rid of full meningioma because at current day, and I am 7.5 years post-operatively, I still have 2.5 centimeters of meningioma in my cavernous sinus that is inoperable, untreatable, can't do radiation, any of that, because of the closeness it has to the other structures, which are my pituitary gland and my carotid artery. So every 3 months, I am in imaging, getting MRIs for that area to make sure that those cells are not maturing and growing. Because if they do, I'm out of luck. There's nothing that can be done. Meningiomas grow very slowly. It might take years for it to encapsulate other areas, but it will eventually do that if they become active. They're not dead. The cells are not dead, but they're not active yet. They're still the same size, in the same position, in the same location as they were on August 24th, 2014.
Wow.
But that's what I have to live with. Now, to talk a little bit about Meningioma Brain Tumor Network, Inc., that's how it was developed, was because I know that there are other folk out there, particularly women, because this type of brain tumor affects women between the ages of 40 and 70. Those are usually the onsets. They come in different locations in the brain. I happen to have mine in the right sphenoid wing, but there are people that have them in the frontal area, some in the occipital area. I just happen to have one in an area that is very, very difficult because of so many other structures that are on that side. Meningioma Brain Tumor Network, we are a support and advocacy organization. And what we're thriving to do as we grow, we became founded in 2019, and I must give Dr. Ek the props for that, because I read his research in March of 2019. And I contacted him after I had read his research and asked him for an audience, which he gave to me. And we ended up being on the phone, I know, well over 2 hours. And then about a month later, I get an invitation from him. And the invitation was that in his role at Baylor Scott White, he has a symposium every year. And he invited me to be a speaker at the symposium. And that week, when I left that symposium, I came back and I called one of my dear, he trained under me years ago. His name is James Stewart. And I contacted him and I said, I want to start this nonprofit, but I want you to help me co-found it. And at the time he was living in North Carolina. He's now in Florida, but we got together in Charlotte, North Carolina, and we wrote the business plan. We submitted it after I asked numerous people to serve on the board, which you serve on there, my son, and so does Dr. Ek. We got our IRS approval within 8 weeks. We started running, and then the pandemic hit. And once the pandemic hit, everybody went into hiding. We are just now starting to get more momentum. We're hoping that your show will enable us to do that outreach that we're looking for, because my focus is to help find, and Dr. Ek can speak more to this, we both have this vision of starting what we call a consortium, a registry, if you will, to identify people of color with brain diseases. Now, of course, my emphasis will be on meningioma because I know that very, very well. But because he's neuro-oncology, he's looking for every avenue that we can to help identify people of color, African Americans, and I hope he talks a little bit about his African group, which I was a part of their meeting in February and got to talk about MBTN as well. But we're looking to identify more people, and we are hoping that this platform allows us to do that. When we say more people of color, because MBTN, we have the strategies that we can help. We know we can help, but we don't know who the people are. If you go to my website, you will see several meningioma survivors. Most of them are Dr. EK's former patients. And I met them at that symposium. There are several of them that are ambassadors for MBTN, but we haven't even scratched the surface yet. What I say that's different about MBTN and the other brain tumor organizations, most of them focus on cancerous brain tumors. Although meningioma is not considered cancerous, it still manifests itself the same way that cancer tumors do. Our treatment plans are identical to cancerous tumors. Identical. The resection, some type of therapeutic, whether it's chemo or radiation, or repeated surgery. Those are our options. That's the same way for cancerous types of tumors in patients. The other part of meningioma that we do outreach on is helping to work with the caregivers. I was in convalescence for 3 years and had to call on numerous people as I went through the phases of recovery. Brain disease takes away a lot of what we know. I had neuropsychological evaluations. I even said, find me somebody I don't know, because that's my field. And I did not know this gentleman. And when I went in to get my battery of tests, which was 2 years post-operatively, it took me until I started this organization to even read the evaluation. And the reason why it took me that long to read it, because part of the evaluation, when he got to the visual relations section, I couldn't answer any of them. Then I knew I was in trouble. I had memory and recall deficits. I had organizational deficits. I knew all of that. And when I could not put those items together, I remember him looking at me and saying, "You're okay, you're okay." But when he wrote that report, he says, "I watched her try to rationalize why that was happening to her." That's what's in his report. It's a 7-page report. A lot of us don't even get the neuropsychological evaluation. We need to have those kinds of things before surgeries and after. We need a baseline so we know where our cognitive functioning was in existence, because you're going to lose some of those properties. It's no question about it. But how much, how rapid, and whether they're permanent or not. We won't know that unless we have a baseline. So MBTN looks to help with all of that, helping patients structure that, helping families structure that, helping families and caregivers figure out ways to work with the survivor in maintaining a quality of life, because you will lose a lot of your skill sets, and they don't come back oftentimes. They're gone. You have to find compensation strategies for it. I have found some that are succinct, but they're not where I would like to have them. And I probably won't ever get back to that again. And I have to live with that. But those are not conversations that are ever had. MBTN and what we offer will help you navigate those waters, because I've been there. I know what it's like.
Wow. Okay. Not get sentimental, because I say, you like my other mom, not get sentimental. All right, so because we're down to our last couple of minutes, Dr. EK, talk about some other things that you do in conjunction with this, like Mom was alluding to. Talk about some of those things.
Yeah, you're right on that, Dr. EC. I think if we look at cancer in general, especially brain cancer, in the last 20, 30 years, most of our focus have been on quantity. How do we try to make sure that we can find the cures so that patients can live forever or can live longer? But the question becomes, if you go through a surgery and you come out and you're wheelchair bound or you're bed bound, what have we done to you in terms of your quality of life? So in terms of my own research, what I've been doing lately is not only to focus on finding the new drugs or the new blood tests to augment what we are currently doing right now, but I've also been focusing most of my research on quality of life issues in brain cancer patients, including meningioma patients. And I think those are the areas where we really need to continue to do the work in order to find that balance. In addition, I want to also thank Dr. Coleman for coming up with the Meningioma Brain Tumor Network, which is an organization focused on creating awareness and advocacy in communities of colors. Because when we look at the statistic, meningioma as a tumor, even though it might be benign, it tends to affect more Blacks and more folks within our own communities than the rest of the population. And yet, when we look around, most of the resources that are currently allocated to brain cancer are only allocated to glioblastoma or to some form of childhood cancers or childhood brain cancers, such as medulloblastomas or DIPGs, or what I call diffuse intrinsic pontine gliomas. But yet, meningioma, which are by far the most common brain tumors that we know and tend to affect more people of color, we do not have any organization or any resources allocated just to study these meningiomas so that we can better come up with ways to continue to improve the care of those patients. And I think if we learn anything from this, what I think the plan should be one, to continue to focus or draw attention to meningioma, especially within our own community, and also to get involved with our own stakeholders or those who make all the public policy as regards to allocation of funds for research, so that we can better study this disease and come out with more treatment plans or strategies that can help our own, that can help the community. I think that is a lesson from this. And the last thing I always tell patients is that once you get diagnosed with this tumor, it's not just good enough to go home after your treatment, especially when you start suffering from some of these side effects that might affect your quality of life. Make sure you get involved. Talk to your local politicians, mayors, Congress people, the president. Draw attention, tell your story, give some interviews, but also at the same time try to get involved in terms of fundraising, because that is the only way we're going to be able to start to make some differences in these diseases.
Okay. How do people get in touch with you, Dr. EK? How do they get in touch with you?
One way to get in touch with me might just be to send me an email, either using my first name, ekokobe.fonkem@bswhealth.org, or you can contact the Meningioma Network, Inc., where Dr. Coleman happens to be the founder and CEO. She knows where to track me, or you can just call me directly. And those are the best ways to get in touch with me.
All right. Dr. Mama Joe, how do people get in touch with you if they want to learn more about this or the organization?
They can go right to Meningioma Brain Tumor Network's website. If you just type in a search bar, Meningioma Brain Tumor Inc., it will automatically populate and they can see every one of the pages on our website. And then my email is also noted there and my phone contact.
All right, everybody. So there you, of course, this is the part one of a necessary part two that we will have to schedule at some point because there were some other questions I really want to ask. We don't really have the time to do tonight. So I will be getting with you two so we can have part two and really get to some other stuff. But special thanks to Dr. EK and again, I always call her Dr. Mama Joe over here for being amazing guests, especially to Mom for sharing her story. And again, I have to laugh because I know her. So to hear this story and hear her tell it, I'm like, this is so you. Like this is so you. Even in the midst of this, you're still like the boss. And it's like it's amazing, but we should all be that involved in our care when these kind of situations arrive. So definitely check out the website. I'm honored to have them both with me. And this will be up tomorrow. And I will see you guys. You two hang on. I'm gonna stop the recording, but I will see you guys on Leadership Blend. Next week, we'll have some great guests. Go to ricecommunity.com, Rice with a W, to find out who those guests are going to be. And also check out Blend Blazers podcast, my new one, where we talk to leaders in all kinds of venues, all of the areas. So I will see you guys very soon. All right.
Thank you so much for your time, Mr. Wright.
You can have